And thank you. And you may think it's a great follow-up to that story, but wow, I think I've got a bit of a hard act to follow, really. It is completely inspirational and tremendously brave to come to such a conference and to give such an honest reflection. And we thank you all, because there's no better learning than actually from the end user of all of this. So thank you. So I just want to come to give you some updates really on the lower limb work stream that's been happening with the National Wound Care Strategy. You'll have heard from Una yesterday giving you over the arching messages, but this is the lower limb stream. So I just wanted to really focus in on that. You know where this started. The whole journey that we're currently on through the UK started from this now seminal piece of research by Julian Guest and Kath and Peter Vowden. And many of you will be able to question the methodology of the paper as if this truly a reflection, because to many of us that tremendously disappointing figure of only 14% of patients getting ABPIs with lower limb ulceration didn't feel real. And as much as you could criticise this paper, you can actually stand up and say thank you to this paper at the same time, because actually this has really painted the significant burden that we've got throughout the UK. Not just us to clinicians, because it's felt like this for a while to us, but to the payers, to the Parliament, right up there to Whitehall. The greatest thing about this paper, me being a vascular nurse consultant, and many of you being the arch enemy called tissue viability nurses. But am I allowed to say that? I might get struck off. Is that I've known, and I think you've known for a long period of time, that's been an elephant in a room called a leg ulcer. But because of the way the NHS England has been funded and been driven, you guys have become so focused on pressure ulceration that at times I often thought, have you become pressure ulcer nurses, not tissue viability nurses? And I think this paper really helped us all to move forward to say, a third of the wounds are on the lower limb. So can we concentrate on the highest population and turn to face the elephant in the room to make sure that these patients get the appropriate care? But you'll all know the research. And you'll all know the evidence base that we use compression therapy for simple venous leg ulcers. And you've got healing rates in reported literature at 98% at 24 weeks. So how on earth can we have research literature at such an extreme, but true UK practice tells us that at 12 months with a simple venous leg ulcer, at 12 months we'll only have 47% of the population healed? Why is that, and how that can be? And also, what does that do to our services? If you're carrying 50% of your caseload historically year after year after year, how long before your services become completely and utterly unsustainable? Many of you will feel on that cliff edge right here and right now. But when you look at this, it's all to do with unwanted variations in clinical practice, and this is the heart of what we need to change. We know that there is poor assessment and terrible poor diagnosis in terms of lower limb disease. And there's an underuse of evidence-based therapies. There's an underuse of the ABPI. There's an underuse of compression therapy of its whole. And there's a certain underuse of venous intervention as a cure for that venous disease. And unfortunately, there's an overuse of ineffective therapies. Reduced compression bandaging of any degree is subtherapeutic. It's like giving one paracetamol. If any of your patients are in reduced compression, you need a true rationalisation why. And please none of you argue to me it's to do with patient compliance, because I can provide you a whole host of data to say that it's actually not. It's probably your health beliefs that you believe the patient won't be able to comply with that therapy, hence why they're currently in subtherapeutic compression. But on top of that, we've got a huge problem in terms of national variation of commissioning. How can we have leg ulcer services commissioned in some places, no access in others? How can we have practice nurses allowed to do ABPIs and apply compression therapy? In some places, they can't touch a leg ulcer. In some places, you have to refer to a clinical specialist, so there's nothing can happen out in primary care. How can all that variation be based on best practice? And this is what came together. It's already been referred to as one of the founding factors of why we brought Legs Matters together. But this is awareness at the highest possible level. But the one thing about what Betty's stories did is it actually associated this poor care with cost. If I talk to any of you about cost improvement programmes through the NHS, as a clinical nurse, it feels like you're going to take a nurse off me, you're going to downgrade some of my registered staff to unregistered staff, or you're going to take a bed off my floor. That's what it feels like. But actually, this is cost improvement that we can all get to, because you're going to save 10 times the cost at the same time, improving patient experience, improving patient safety, and improving effectiveness of care. What nurse wouldn't get behind those 3 foundations of our practice? And this is why the National Wound Care Strategy came into place, because we wanted a vision, really, of getting rid of this unwanted variation, to be able to really articulate what is a good practice. How can we articulate that to our commissioners? How can we benchmark that to ensure that we've got consistency throughout the UK? So you'll know we're about here at this moment in time, halfway through planning and halfway into starting implementation. It feels rather scary, I must say. For the first 6 months, I don't think any of us knew what we were doing. Even Una, who has led this campaign brilliantly well, still had uncertainties in the first 6 months about what we were able to achieve. But you'll know it's based on 3 clinical work streams. It's based on surgical wounds, pressure ulcers and lower limb ulcerations. But it's also based on a foundation of the requirements of the pillars of practice to make this work in terms of education, workforce, research, supply and demand, and then the massive one called data and information. We have got highest level buy-in. We have chief nurses of the North involved of this and some very big names involved of all of this campaign. And we're linking with the stakeholder groups in terms of patient forums, industry, to be able to make sure that we get this right. So this is us. This is the lower limb group. You can see there's quite a smattering of the people that's on this panel today is within that. But we're actually linked to some very high-hitting names within research. So we got together as a group of clinicians, and the first thing we said is, how come that's possible? How come is that possible? How come you can have a foot wound, but if you've got a diagnosis of diabetes, you get to see an MDT specialist? But if you haven't got diagnosis, off you go to a single-cell practitioner. How is that allowed on a diagnosis of diabetes? Whatever diagnosis do you know that actually can precede the fact that you've got an ulceration? That's actually the confounding factor of where you go. How is that right? And then the next one that we loved was this one, heel ulceration. Brilliant. If you're defined as pressure, you'll go to a tissue viability service. If you decide an arterial disease, you might go to a vascular service. If you're defined as diabetes, well, you might go to a podiatry service because you might still only have a pressure ulcer, but you might actually get access to an MDT. How is that right? How is that one somebody's opinion of what is your underlying cause able to direct you to the appropriate service? And the problem is, if you think about your own organisation, there's variation in your own organisation. If a patient has been in hospital and comes out with a heel ulcer, if they are diabetic and have a background of arterial disease, in my organisation you can end up with any of those. There is no clear consistency of message. How can that be right? But we know that that's all right having those opinions, but any recommendations that we were going to make has to be very much embedded in evidence. And this is why we worked very closely with the research group, because we are all believers of empirical evidence. And we all believe in this hierarchy of evidence, that the things at the top we should be implementing. But at the same time, it's really difficult to get those things at the top in wound care. A lot of what we do is based on our intuitions, not on a foundation of science. But does that make it wrong? Potentially not. And the problem is, if you look at Cochrane, their wound cupboard would be empty. And that doesn't help us in terms of how we deal with these patients, because I'm not that bothered that you haven't got evidence base of a certain product. But I can tell you now, if you don't manage exudate, you'll have peri-ulcer maceration. So I don't care that you haven't got me an RCT to be able to prove that. We know that we have to treat the symptoms of the wound wherever we can on a foundation of evidence, but at the same time in a practical fashion. So when we got together, it was very difficult in the first instance to be able to decide what research we were going to believing and embed within our recommendations and what we weren't going to look at. And actually, there's 4 seminal papers and 4 seminal bits of research that the research group believed that they were high quality and that we should embed within our foundations of our practice. The first one is the Cochrane Review. No surprise there. The Cochrane Review tells us that compression therapy works. Tells us that the higher the compression, the better the outcome. And unsurprisingly, you can deliver that by a number of bandage systems. And there is no true evidence to support one bandage system over the other. So that's a good foundation to put us on. The next one that they deemed was a worthy piece of research was venous FAR. And many of you know the impact of venous FAR. This is a massive randomised control trial that looked at multi-layer compression bandaging versus compression hosiery kits that provide 40 milligrams of mercury pressure. It was a head-to-head trial looking at healing rates, patients' concordance and quality of life. Patients were followed up for 12 months, and at the end of the day, they found out that compression hosiery kits heal as well as multi-layer bandage systems. You also get a little bit of cost saving by using compression hosiery systems. But actually, to me, the biggest gain is actually of reducing your risk of recurrence, because you're dropping it from 23 down to 14%. And if you think of the reasons why, well, that's quite clear. If you've got a patient with a venous leg ulcer, we need to be educating them on the underlying disease pathophysiology. If you put a patient into a hosiery kit, they see the connection in terms of that improvement of that wound with that compression hosiery kit. And as the wound gets smaller and smaller, gets better and better, you've brain trained them in thinking it's that compression. How many patients have you had that you've healed in multi-layer bandaging? You've got them to heal, you provide them with compression to prevent recurrence, and they never wear them, because they don't see the link with the underlying disease pathophysiology. And for that reason, and the fact that patients can self-care and it's slightly more cost-effective, the research group thought that we should include this within our recommendations. And the other one, if you were here this morning, you'll have heard about this from Jane Nix, who talked about the NIHR research that's going on, is the EVRA trial. So EVRA was launched, the final results was published last year at the TVS. And this is a multi-centre parallel group of 450 patients that was randomised to receive venous ablation early or later. Both groups had full therapeutic compression in place. And they found that if you ablated the underlying venous disease, you healed patients quicker. And this was statistically significant, but you healed patients quicker by 30 days. 30 days is massive. 30 days is massive in terms of cost. 30 days is massive in terms of service demand. And 30 days is massive in terms of patient suffering. And when you were able to ablate the veins at the same time as providing therapeutic compression, there were documented healing rates at 85% at 24 weeks. Imagine if you could get that figure in your clinical practice. That would really revolutionise your caseload that you're currently managing. There's further evidence, though, for venous disease in terms of the ESCAR study. This has been published some time ago now. And again, if we treat your underlying venous disease, we'll prevent your risk of recurrence substantially. And what we need to do is this already embedded within NICE national guidance. It already states quite clearly that if you have an active leg ulcer, you should be referred to a vascular centre. We need to make this happen throughout the UK. We need to embed that association with a venous ulcer with the underlying disease pathophysiology. And I challenge you all, stop seeing a venous leg ulcer as a wound. See it as a weed. Do not bother chopping the dandelion heads off it. Think of the roots. The roots of this venous leg ulcer is within the venous system. If we can ablate the roots, apply appropriate compression with a good wound management programme, then actually you will get these patients to heal quicker. Would you want to be suffering from a venous leg ulcer on venous hypertension in compression therapy for the rest of your life in terms of a palliative care? or would you like an operation to be fully cured of your venous hypertension? There's certainly no real question to ask. So that's the foundation of evidence, and this is what we've currently produced. This is a clinical navigation tool, and I've made it so small that none of you can read it, so you can't actually question me on any of it. But actually it's broken into 4 easy compartments. So the first bit is about the initial diagnosis. And basically we're saying, what are the red flags? When should you say, hey up, this is bigger and bolder than me. This needs referring into a tertiary centre on an urgent basis. But it's saying you're allowed to provide first aid compression initially without an ABPI. Get them into a British Class 1 stocking, but that is only first aid. That's only first aid to allow you then to get your ABPI assessment in place. If you can do that on the same day, I would say that's more gold standard. But I appreciate that many services haven't got the opportunity to do an ABPI on the same day as seeing a skin tear. But it tells you how to make that diagnosis, and it asks you to ask yourself a simple question. Is the wound on the foot, including the heel, or is the wound on the leg? And the anatomical location of the wound is going to be determined who you get referred to. It's going to be as simple as that. So we're going to get away with this. It's the diagnosis that's going to make a difference of who you're referred to. We're going down to what is the anatomical location. If the wound is on the foot, I don't care whether you've got diabetes or not, you are going to see a podiatrist specialist. Because we know the skills of that group of clinicians are the best in terms of managing that patient, to be able to recognise those underlying disease pathophysiologies. Because you can get neuropathy without diabetes, but at the minute, who manages that? There is a huge challenge with this though, because at this moment in time, the model's saying that if you have a pressure ulcer on your heel, you'll be referred to a podiatry service. Now, have the podiatry team got the skills and knowledge in terms of offloading? Yes, they have. Have they got the skills and knowledge in terms of surfaces, mattresses, support, cushioning, how to manage other areas of pressure that's at risk? So there's a big question in terms of education and workforce, but that's for us to deal with, not you. The next recommendation is simply looking at leg ulceration, and it's asking you to make that diagnosis, and it's asking you to refer to vascular to embed that venous ablation within every patient that you see. It's asking you to ensure that every patient is in 40 milligrams of mercury pressure unless they've got peripheral arterial disease. It's saying use higher elements of compression if you're failing to heal. 40 is not the gold standard in Europe. If you look at any documentation in Europe, they talk about getting 60 milligrams of mercury pressure on a leg. So we need to think about when do we need to use higher levels of compression. And the final piece, it talks about what and when to refer into. How do you escalate up? Where do you send your patients if you are a practice nurse and that patient's failing to heal in best care? Well, you refer them onto the tissue viability service often. What if the tissue viability nurse or the specialist clinic, though, is also failing to heal that patient? Who do they send them to? Because at the moment, it's a smattering of dermatology, plastics, vascular. Do we need to look at developing complex MDT clinics across the spine of the UK to be these specialist referral centres? So where have we got to date? Well, we've got a group of very vocal clinicians round a table. And we have been able to focus on the questions and the variation that bothers us every day in clinical practice. Those being diabetic patients always getting to the MDT, patients with foot ulcers not getting access to an MDT. We've focused on the problem with heel ulceration, and we're trying to standardise the care of patients with leg ulceration. Our conversations have just begun with the data and information services, and I must say to you, you all know that the systems don't talk to each other. My God, it's bigger than you think. The data and the information throughout the UK is an absolute minefield and a headache. And at this moment in time, we can't tell you any data of a consistent, reliable method. We haven't got that. And do you know what we're aiming to do, the first thing that we're aiming to do, find out how many patients we've got out there? Because at this moment in time, we can't even tell you that. And that seems like a very small step and something we should be able to easy to do. But at least we know the number of patients out there. We can look at variation in numbers, and that may give us some indication of quality of care. We're in direct conversation and consultation with the education and the workforce team, because education is going to need to change. Health Education England is looking at clinicians. No matter whether you're a podiatrist, a nurse or a physiotherapist, clinicians should have a range of skills. These should go from basic, intermediate and advanced. And actually, what difference does it make whether you're an allied health professional or a nurse? You can deliver similar service if you've got the same capabilities of your practice. We need to look at the research gaps. A lot of what we are doing at this moment in time is anecdotal, based on your beliefs. We need to firm that up with some evidence, and we're trying to get some funding to be able to do that through the education work streams. If you have previously signed up for the stakeholder group, within the last 48 hours, you will have received an email with a Survey Monkey on, and that beautiful navigation tool for you to look at, to critique, to question, and to slag off. Are you allowed to say that word? Slate. To slate. You're allowed to slate. You're allowed to slate. Slate. Northern. It means a slag heap where I come from. Coal mines. That's what it means. We would love your comments. If you haven't signed up to the stakeholder group, please do so now. We're going to resend. Yep. Okay. Fantastic, thank you. So we can tweet that, can't we, to get that amendment up? Yeah, we can tweet that amendment. So I thought that were only for the supply chain side of it.
No, it's for the stakeholder council. It's a common box. We're managing it.
Fantastic, thank you.
Double check the...
Right, we'll double check that. We'll make sure the TVS tweet the right email address for you all. So that first round of emails went out this week. If you haven't signed up or you haven't got that email, please re-email us on the right one that's going to be tweeted. That gets all your Twitter feed up, doesn't it? Like hashtagging. Because we would love your feedback. Please be critical of this. We want to amend this. We need to ensure that we're singing from one song sheet. We believe all that's wrote this. We know that we're not the only experts around here. We want this to be fit for practice for us all. So please be very critical of it. We want to get this right if we're ever going to change, if we're ever going to reduce the unwanted variation, if we're ever going to change the care that patients like this receive. Thank you very much.
Thanks to Leanne. We've got time for a couple of questions, if anyone has one, before we stop for lunch. You're all got... Oh, question over here, please.
Hi, thanks for the conference display. It was very good. Can I just go back to what you were saying about using reduced compression? Coming from a leg ulcer clinic myself, I often have this problem. And in terms of concordance, there is an element of that to it. However, we have to go with our pathways, which say if there's any cardiac risk factors, we can't actually use class 1 hosiery. So that often prevents, because we're seeing a lot of people 80 plus and 96 and so on. We refer to vascular. I've had it happen a few times myself, and Vascular have said, you've got the best legs I've seen for a 94-year-old, and send them home. So in terms of that, for us, that's quite frustrating, because we're trying to do what we can, but that's often what we're met with.
Yeah, please don't think from me saying the inconsistency in practice only lives within nursing. Oh, no, it doesn't. There's inconsistency with the practice throughout the whole UK, how they approach varicose vein surgery, that many consultants still believe it's cosmetic, and we're working with the Royal Venous Forum to be able to actually say to patients no, and to say to the medics and the surgeons, you need to change your practice. Now, if you've ever tried to change a surgeon's practice and his beliefs, but what I would say is that there is, you will know from your own field, there's a generational shift, isn't there, with surgeons. The newer ones, those 40 and 50-year-olds, are very open and very welcoming of all of our movement. And we've got quite a few of them sat on the board. We've got some of them involved in the Legs Matters campaign. So we're going to try to change that practice. In terms of the reduced compression, Yes, you have to go on your local guidelines, but what we've got to make sure is the local guidelines are evidence-based and consistent throughout, because there is no true contraindication of using any form of compression patients in a patient with heart failure. So long as that heart failure is not in its acute stage and is appropriately managed, actually those patients will benefit hugely with a degree of compression. But this is the problem, isn't it? How can we have difference in policies and procedures from one organisation to another? How does that help? Because either I'm being unsafe in my approach or you're being neglectful in your approach. How is that right? And how is that decision made on a local level, and what's their knowledge of the evidence base? So there's lots to solve, but be part of the solution.
Thank you. Okay, we're going to stop for, I'd like to thank all of our speakers here today, and a round of applause again for everybody.